Welcome to the show discussing problems and issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about bleeding disorders in the human body. When I left off last week, I listed all the different conditions, medical conditions, that can cause somebody to bleed. Some of them are inherited problems, some of them are acquired problems. I have here a list of 30 different things, 30 of them on this list, almost a whole page of different medical conditions that can cause somebody to bleed, increase the incidence of bleeding. And of course, the number one condition on the list is von Willebrand disease, which is a qualitative platelet abnormality that affects 110 million people across the world. That's a whole lot of folks, okay? And in this country, you have 2.8 million folks who have this condition as well. So it's a major problem. And I'm going to concentrate in this segment on von Willebrand, and of course, subsequently, I'll be talking about several of the other conditions on the list. Yet another article I heard about on television came out last week talking about people on aspirin. 1/3 of them had decreased incidence of clotting in the legs because they were taking aspirin. Well, I don't know what part of the leg they were talking about. If they were talking about arterial clotting, yes. If it's the venous clotting, which is the most common form of clotting that occurs in somebody's extremities, the answer to that is nonsense. And the reason is because, let's take a look at the science. It's very easy for people to write these articles and get a little bit of publicity for a while without paying close attention to the science. In order for somebody to clot, to prevent clots with aspirin, they have to have sufficient amount of platelets. Okay, here's the science. In order for a clot to develop, platelet has to aggregate. Once the first platelet is attached to the second platelet, a material called thromboxane A2 has to be secreted. That's the platelet aggregator. It's a vasoconstrictor. It is the thromboxane A2 secretion that causes the whole reaction of platelet aggregation to take place. That's the first part of the science, okay? Now, the problem with the venous system as it relates to giving somebody aspirin, you just don't have enough platelets and clot that's developed in the venous system. That's why we call it a red thrombus. It is composed mainly of red blood cell and debris, and very, very markedly deficient in platelet. That's the reason why aspirin will not work in the venous system to prevent clot, period. That's the reason. Aspirin is fantastic. There's nothing wrong with aspirin. When one takes an aspirin, it protects the arteries throughout the body, in the brain, around the heart, around the eye, around the kidney, down the legs, inside the abdomen and the aorta, all over, wherever there are arteries or arterioles, that kind of stuff, it protects that. That's the high flow system. Why? Because the high flow system, when a clot forms, is loaded with platelet. That's called a white thrombus, which is made up mainly of platelet and white blood cell. That's the big difference. So if one going to give somebody aspirin, you have to be absolutely sure that they don't have any underlying issue with the platelet. If they have any platelet quality deficiency, you give them aspirin, you're going to get them to bleed. Period. Great though aspirin is as a medication, I take it myself every day. And let me tell you how it works. If you take an NSAID, any one of the NSAID, the effect on platelets lasts 6 hours, a maximum of 6 hours. After 6 hours, the platelet is no longer affected by any of the NSAID, be it from Motrin to Aleve, Advil, whatever. 6 hours. Very, very important to remember that. However, if one takes aspirin, no matter the quantity of the aspirin, tiny little bit, baby aspirin or less than that or half of that, it knocks out the functions of the platelet qualitatively for 7 to 10 days. 7 to 10 days, that's right. If you're going to have major surgical procedure done, major or minor for that matter, you have to stay away from aspirin for 7 to 10 days because that's the half-life of aspirin and the platelet. The platelet will not aggregate and the person will bleed profusely. Profusely. Very, very important to remember that. That is why I told my patients who are taking aspirin to always have that in their wallet that they're on aspirin in case something happened to them and they show up in an emergency room bleeding, be it unfortunate car accident or God knows what else, any kind of a traumatic incident. If they're on aspirin, the doctor in the emergency room need to know because they're going to try to either suture the wound, if it's a wound. They're going to try to treat the trauma in one form or another. If they are on aspirin or NSAID and you didn't tell them, or sometimes they don't know, but if you cannot talk because of the trauma, if they look through your wallet, which people are allowed to do in an emergency room setting to find out who you are, what's going on, the police officers can look at it as well. They'll see a little note, say that I have this condition and or I am taking aspirin, or I'm taking Coumadin, or I'm taking Xarelto, or I'm taking Prodax, or whatever. It's very important. Otherwise, the bleeding is going to continue. They can do all they want to suture that wound, all they want. The bleeding is going to continue, and they're going to run all over the place to try to find out why the person is. So anybody who shows up with blood in the stool or they're vomiting blood or whatever, you need to know whether they're taking an aspirin or NSAID. You also have to be very careful because several of the over-the-counter cough syrups have aspirin in them as well. And people who are not sick with any underlying platelet problem, it doesn't matter. But if they have any one of these underlying platelet issues and they take even something as simple as a couple teaspoons of cough syrup, that can start bleeding right there because the platelet is bad to begin with because they have an underlying disease. So in this country, there are somewhere between 45 million to 50 million folks who take aspirin every day. That's a large number. And aspirin is a great thing. I'm not here to say anything negative about aspirin. Far from it. As far as I'm concerned, aspirin is the best drug ever created in humanity, period. And it's cheap and it's easy to take. People take aspirin for different things. It's not just for clotting. In developing countries where people don't have access to all the NSAID, they have access to aspirin. They treat their rheumatological problem with aspirin. Over here, we have all these fancy medications that we have been advertised on television, and you could buy them over the counter, the Motrans of the world, the Advil of the world, blah, blah, blah. Those are great medications. But we have access to them. In developing country, people can't afford that kind of stuff. It's too expensive. But aspirin is cheap. It's very cheap, and you could find it anywhere all over the world. I think there are very few medications in the world that is used as frequently as aspirin, maybe steroid, maybe penicillin or whatever. So it's very important, but you have to know whether or not you don't have underlying problem. Now, let's talk about von Willebrand, okay? 1.10 million people have it, okay? It affects men and women equally. What it does is that it prevents your platelet from clumping. Because of that, you're prone to bleed excessively. The bleeding, oftentimes people bleed from the nose recurrently. They can bleed from the mouth, the gum recurrently. They can, women in particular, seem to have a propensity to have excessive vaginal bleeding who have von Willebrand disease. They bruise very easily all over the place. So you take a history from the patient. And based on the history, and then you proceed to do a physical examination, then you would begin to do some blood tests. Well, you'll do a complete blood count to make sure that the platelet count is normal, between 130 to 400,000. That's a normal platelet count. You look at the hematocrit, look at the white blood cell count differential to make sure these people don't have any leukemias or other abnormalities that can also affect the platelet even though the quantity is normal. Okay. Then you proceed to do some blood chemistry. You do a complete chemistry profile, which is fine. You do that, look at the kidney test, you look at the liver test, etc. Look at the electrolyte, which is part of the kidney profile. Why is that important? It's very important because people whose kidneys are failing or have failed have abnormal platelets as well. Now, you didn't know that. You're just finding out. Everybody who have end-stage renal disease, who are either on dialysis or not yet on dialysis, have qualitative platelet problem. Not as bad as von Willebrand, but bad nevertheless. You say, well, how so? Well, how so is because the kidney job is to get rid of a whole lot of material through the urine. Well, some of these materials, protein breakdown materials, cannot be excreted by the kidney to the urine effectively because the kidney is sick. And they get piled up in the circulation. And what do? They coat the platelets. As they coat the platelets become qualitatively abnormal. So people who are on dialysis almost all the time bleed excessively because of what I just mentioned to you. So you have to understand that. Even though I didn't put that down on the list, there are so many million people with end-stage renal disease who are on dialysis, and I'm here to tell you all these people, all of them across the line, have qualitative platelet abnormality. When they are being dialyzed, those abnormalities don't manifest themselves because the dialysis process takes out those abnormalities, cleanse it out from the bloodstream. But if for whatever reason they're not being dialyzed or they're not being dialyzed properly or whatever, suffice it to say, people who have renal insufficiency as well as people who have end-stage renal disease have qualitative platelet problem. Further, the people who have renal insufficiency have to be very careful because via a completely different mechanism, the prostaglandin mechanism, if they take aspirin or NSAID, it will worsen the kidney function. So be careful giving this medication to elderly folks because the older they are less likely they have to have good kidney function. So therefore, when you're prescribing medication for geriatric patients, you must factor that into your thinking. Okay, this is clinical academic medicine. Okay, so now that I've told you that, now a simple test. Last week I misspoke when I say second, it's minutes. You do a bleeding time. You stick somebody's finger, wash it with a little alcohol sponge, take a lancet, stick the finger, and you start the stopwatch. And you watching, you bloating it. People, we know, I'm a medical technologist. Believe it or not, I still have my license. I don't know if they're still valid or not, but I still have them. I don't continue to pay for them, so I don't need to reactivate them, but I still have them, 8 of them for that matter. You keep blooding it, and then you're timing it. The normal bleeding time is up to 7 minutes, not second, minutes. Last week I said second, I was joking, it's minutes. Okay, so if it's above 7, it's abnormal. Now that simple test can trigger a whole medical reaction that can save somebody's life. Because you're sending somebody to the OR, you do a bleeding time, which is simple. I just explained it to you. That's all it is. It's simple. That's simple. At least it starts the process. They have an abnormal bleeding time. Once they know that they have an abnormal bleeding time, then it is the job of the physician, he or she, to refer the patient to a hematologist to determine what's the reason for it, rather than sending somebody to the OR just because the PT is normal, the PTT is normal, the INI is normal. Those are important, but that covers only the coagulation profile, has nothing to do with somebody's platelet, qualitatively. The fact that you do a CBC and the platelet count is normal, you say it's okay, the patient can go to the OR, But how about the quality of the platelet? Well, that almost always, if you take the history properly from the patient, you will find out that they bruise easily, and they've had recurrent nosebleed, and so on and so forth. So that should trigger a workup. Now, the workup for von Willebrand is very expensive and is very extensive, but it is worthwhile because you have three different types of von Willebrand disease. Okay? You have type 1, which is where the factor 8 level is low, because factor 8 and the von Willebrand factor are married to each other. I mean, this is like conjoint twin. They're together. You have to cut them apart to remove them, okay, as it were, okay? Can't talk about factor 8 without talking about von Willebrand. They are together. So, and von Willebrand, number one is low factor 8. That's all the abnormality. Is the most common form and is the less severe form. Then you go to type 2. Now we're talking. Because type 2 has several different subgroups. It's much more severe than type 1. You have 2A, 2B, 2M, and 2N. These are the different subgroups of von Willebrand type 2. These are different mutations. People who have type 2 with different mutations. And you need to know these things. Okay. Then we come to type 3, which is the most severe form of von Willebrand, where the factor 8 and von Willebrand factor, that's just about 0. And these people really will exsanguinate. So what do? What's the test? Well, you order a von Willebrand profile from the laboratory, complete profile. That's all you have to say. Von Willebrand complete profile. And then the laboratory folks will sort it out. You don't have to say anything else. By the time you get your result, they would have put that blood specimen through the entire workup, all the way to the end, and you will wind up find if it's normal or if it's not abnormal. And if it's abnormal, which type it is, and so on and so forth. That's what you do, okay? Now, you don't do that for everybody who you're sending to the OR. It doesn't make sense. It doesn't make clinical sense. It doesn't make good judgment. However, a bleeding time, my friend, is so simple, and it's cheaper than this bottle of water to do, okay? I mean, I have done hundreds of them the years that I worked in the lab, but then things have become so much more fancy that people get away from that. I used to have my little basket. You go to the pediatric floor, you go to the nursery, you had to stick the heel of the infant to get blood. You also do the bleeding time because infant can be born with abnormal bleeding issues, okay? So it's not only important for von Willebrand, it's very important for a whole host of other things. So why isn't bleeding time included in the pre-op profile that we do all day long for people who are going to the OR is beyond me. I have nothing to say about these things. People don't pay, the students pay close attention. The interns and residents that I spent all these years teaching pay close attention, and happy that I'm able to impart knowledge to them. My patients are very important, but the powers to be, I'm not the favorite. What I have to say does not make an impact on them because for whatever reason, I'm not the one guy that, because they can't mess with me. They can't put anything over on me. They can't play games with me, and I don't I'm not a member of the club, as it were, and whatever. For whatever, it's their reason. I can't tell you the reason. You could figure out yourself, and I couldn't care less, frankly. As long as my patients are happy and my students are happy, my interns and residents that I spent so many years, and of course I've gotten a tremendous amount of satisfaction out of it, all the work that I've done. And look at the screen, the student did all that for me. So I'll continue to do it because nothing is more satisfying to a teacher when your students give you positive feedback. The same thing, nothing is more satisfying to a physician when your patients give you positive feedback for things that you've done for them that have either cured the problems, eased their pain, and so on and so forth. That's what doctors are there for. And there are a bunch of great doctors out there who are doing this 24/7. As I said last week, practicing medicine is a very stressful, difficult position for anybody to find themselves in, but it is a high privilege. And I take that privilege extremely seriously. Extremely seriously, okay? And 24/7, I give it everything I've got. Every patient that I agree to see, I want that patient to feel that this is the last patient I'm going to see before I die, and I ain't going to mess up. So that's my feeling. That's how I deal with it. So in any event, now we made a diagnosis. The patient has von Willebrand disease. So what do we do? Or someone shows up in the emergency room. They're bleeding. They told you they've taken aspirin. They told you they've taken NSAID, and they're bleeding from whatever the source of bleeding is. Then what do you do? Well, there's a medication out there called desmopressin. Another name for it is DDAVP. DDAVP or desmopressin. This is a medication that was used many, many years ago to treat issues involving pituitary tumors or whatever. But it turns out that medication should be in every emergency room available for people who comes in who are bleeding. Because you give this patient one dose of desmopressin slash DDAVP, the same thing, 20 microgram of that medication and 50 cc's of normal saline, and you give it to them intravenously over a half hour. That automatically increases the level of factor VIII von Willebrand, and the patient's going to stop the bleeding, just like that. And if you're preparing someone to go to the OR to have surgery that you know also have von Willebrand disease or have been on aspirin, that's going to take 7 to 10 days to get it out of the system, and they have to go to the OR, they show up in the ER in an emergency setting, you must know to give them desmopressin, 20 microgram and 50 cc's of normal saline IV over a half hour. You're going to correct the qualitative platelet abnormality that the aspirin has created, that the NSAID or the NSAID has created automatically. If it is an elective procedure, you give it to them an hour to an hour and a half before the surgery, and then they should be fine. Now, if the patient has the disease, they're not going to the OR, then it comes in nasal preparation. They can inhale it. They have it in a nasal form. They can puff it. It works fine. All my patients who are being treated for von Willebrand, they are on this medication. They self-treat themselves. There's those who prefer to self-inject it. There's all sorts of different ways of giving it, but it is a lifesaver. But for it to save your life, you have to know you have the disease to begin with. And I'm here to tell you 15% of menstruating female who present to doctors who have fibroid, and everybody thinks it is the fibroid that's causing the excessive bleeding, according to the literature, turns out to have fibroid, but they also have von Willebrand. That's a large number, 15%. So you could treat the fibroid all you want, they could still continue to bleed. As a matter of fact, you might make them even bleed more if you're going to take them to the OR to remove the fibroid surgically, not realizing that they have von Willebrand, then all hell is going to break loose. Okay? But you see, you cannot, medicine is not mechanic. It requires a lot of thinking. And I'm not going to sit here and apologize, because as a medical educator, yes, thinking takes a lot of time. Understanding the mechanism of how science works before you use it in the clinical practice of medicine is hard, it's complex, it's time consuming. But that's the responsibility you've assumed. If you can't handle it, refer the patient to a medical center. There are tons of medical centers throughout this area where a lot of heavy-duty research and teachings are taking place, where the patient can get the care they deserve. Simple as that. Because in the community, It is not the responsibility, the way I know it, of community doctors who are so busy, so stressed, to read every articles, to go listen to every lectures, because they're not involved in teaching. I'm not criticizing them. That's just the reality of it. When you go through training at the end of every June, when you're going to shake your hand and say goodbye, it was nice knowing you, it's only about 0.5 to 1% of the trainees are going to be kept in those medical centers to practice medicine. So the rest of them have to go in the community to earn a living and treat patients, and they're doing a great job. But you can't expect them to know everything. And the problem is those who don't know and don't do right by the patient by referring the patient for a second opinion or whatever. That's an issue. But I'm not a regulator. I've just been a victim of regulation myself. It's a brutal thing. I wouldn't wish that on anyone. So for people to use their own judgment, I'm not here to criticize. I mean, my colleagues are under stress. They're doing a tremendous amount of job. They're providing great services to patients throughout the world, throughout the country. Just because I do clinical medicine locally and I also happen to teach, that doesn't make me any better than anybody else. It's just that I'm a pain when it comes to taking time to research everything, to do everything in very detailed way. I wouldn't go to sleep until the problem is solved. That's the way I am. That's the way God created me. I'm not going to apologize for that. That doesn't make me any better than anybody else. I don't pretend to be either. So this is how you would treat von Willebrand disease. That's how you would prophylax a patient that's going to go for surgery, etc., etc. Listen, I'm going to stop here. Next week, I'll continue to talk about bleeding disorders in the human body. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.